joining us today as we learn what advancements are being made in ALS research. My name is Linda Kern, and I'm a social worker and patient services coordinator with ALS of Michigan. Joining me tonight is my colleague and patient services coordinator, Judy Fortuna. Also joining us tonight is one of our ALS of Michigan board members, Andy Roisman. Our speaker this evening is Dr. Stephen Goutman, Assistant Professor of Neurology at U of M Hospital. Dr. Goutman's medical school training was at the University of Chicago, Pritzker School of Medicine. His residency was at Cleveland Clinic Neurology. Dr. Goutman's fellowship was in neuromuscular disease at Cleveland Clinic. He is board certified in electrodiagnostic medicine, neurology, and neuromuscular medicine. Please help me welcome Dr. Stephen Goutman.
Great, well, thank you. It's really an honor and a pleasure to be here tonight to talk to you. I see faces that are familiar to me and some faces that are not familiar, so thanks everyone for coming out and braving the traffic and the weather to make it here tonight. So I thought I was asked to come and give a talk about the state of ALS research, and I thought I'd come in here tonight and kind of give you this overview of ALS, the 30,000-foot overview. Talk about some of the challenges that we're having with research, talk about some of the research priorities that I think we envision as a research community, talk about this link to the environment that we're beginning to understand at the University of Michigan, and really why I think everyone should participate in research and the importance of it, and I'll go through the studies that we're doing at the University of Michigan. We all, of course, know Lou Gehrig. A little quiet, but that was this is Lou Gehrig's farewell speech. And he, of course, was the first baseman for the New York Yankees, was really a tremendous baseball player, won the Triple Crown, is considered the Iron Horse for his streak of games. And what I've graphed here is actually a comparison of Lou Gehrig's batting average in red and a more recent baseball player who I think we consider is pretty good, Miguel Cabrera. So Lou Gehrig's in blue and Miguel Cabrera's in red. And we can see that Lou Gehrig was really a tremendous baseball player until his batting average dropped off as he was getting weak. We've really gone through a tremendous a public awareness campaign of ALS recently with the Ice Bucket Challenge. Those of you who know Jana, she really tremendously enjoyed dumping ice on my head. This caused a real spike in the interest of ALS and people searching for ALS on the internet. It led to a huge increase in people looking for Wikipedia websites on ALS, and it spiked a big increase in donations as well. And so all of that was really a shot in the arm to really create awareness for ALS. This is not an audience that I need to explain what ALS is. I think all of us are touched by it in some way. But in the simplest sense, it's a disorder of what we call the motor neuron cells located in the brain and in the spinal cord. And these motor neurons are in two spots, and so I try to usually demonstrate this in clinic, although it would be great if I had a model. So here's where we call these upper motor neuron cells. It's in the brain, it's in the head. And in the spinal cord, see this red circle here, you see the location of these lower motor neuron cells. And this is a cross-sectional image of the spinal cord. You see the location. So if you imagine me sort of laying on my stomach, facing out, this is unique for neurologists to talk about this because we're used to seeing these on MRI images, which are reversed. But if you imagine me laying on my stomach, this is sort of the lower part, so against my stomach. This is where these motor neurons are located, the interneuron cells. So the problem with ALS is that for reasons that we don't understand, these motor neuron cells die. And of course we all know the clinical presentations of ALS with weakness of the hands, the arms, the legs, the tongue, and the neck. We have some real challenges in our understanding of ALS as we start moving towards a cure. And the first challenge that I'd like to illustrate to you is I think we all agree these are orchids. And I think we all say these are flowers, but we wouldn't call all of these orchids the same. clearly see differences in these orchids. Similar sense, these are poison dart frogs. I think we all can recognize their similarities, but there's some real differences, and apparently the colors, I found this out, the colors indicate their likelihood of being the least to most poisonous. That depends on the insects that they eat, so I'm not a poison frog, dart, poison whatever expert, but I think we can all realize that there's really some key differences in these frogs. Well, we group ALS as one disease, but how can I explain the difference between somebody here on the left that has weakness of the arms and their legs compared to somebody that just has weakness here affecting their ability to speak and swallow? At the same time, how can I explain that one person just has a lot of weakness affecting their arms and their legs, whereas somebody else is really stiff and spastic? I can't comprehend that these are the same exact disease. Along the same lines, why does this person look like only their hands and feet are weak, whereas their shoulders and hips are strong? And this person here has weakness only on one side of their body, like they had a stroke. And finally, how can we explain that this person has just weakness of their arms, and this person just has weakness of the legs? So I think as I know many of you go to support groups and think about ALS, and you say, look, the people that I interact with, they don't look like me. They have a different disease. And what I will suggest to you is that we're beginning to understand that ALS is not just one disease, and that there's heterogeneity. We need to really begin to understand why those differences are occurring. One of the other challenges that we have with ALS is that motor neuron function changes over time. And so we can think of this as sort of water flowing down a stream. You get your onset of your disease way up here, but it's not for some time when one starts to develop symptoms. During this course when motor neuron cells are dying, we actually call this the pre-symptomatic phase. This is really a key phase of the disease where ideally we would want to be able to provide a treatment at this point to really arrest the progression of ALS. It's not till further down when the diagnosis is made. And so we think about this water running down the stream. As the water runs down, the motor neuron cells are being lost. But you know, we really can't, we don't want to be moving forward looking in the rearview mirror, right? We don't want to know where we've gone. We want to turn our car around. We want to drive upstream. And we really want to figure out how to face these challenges. And so what's challenge number one? Well, challenge number one here is moving the diagnosis forward, right? So if it doesn't take a year for one to start having symptoms and then be diagnosed, that's that major frustration, right? I was starting to get weakness in my hand, and my doctor said I had carpal tunnel syndrome, and I had surgery, or somebody said I had a problem with my neck, and I underwent surgery, and I just kept getting weaker. Well, how can we make that diagnosis occur earlier so that we can really target our therapeutics at the beginning, at the most earliest signs of having disease? On a similar token, we have to better understand the risk factors of ALS so that eventually we can stop it from occurring altogether. And so when we have a drug or a therapy that treats and stops and reverses ALS, we want to give this at the earliest possible phase. But our understanding of ALS has changed from the 1990s to the 2010s, right? The world has changed around us, and our understanding of ALS has also changed. So in the early 1990s, this is when we're thinking of when riluzole underwent the clinical trials, and when the first ALS gene, the SOD1 gene, was discovered. But over these 20 years, a lot's changed. So back in the early 90s, we thought there were only a few genes responsible for ALS. Now we know there's lots. There's potentially over 100 genes that have been linked to ALS in some form or another. We considered it one disease. Now, as I demonstrated earlier, we know it must be more than one disease. We can't explain it as one disease. We didn't know the causes of sporadic ALS, but now we think there's a good link between the environment and the cause of ALS. And we thought that ALS was a really rare disease, but now we understand that the lifetime risk of one getting ALS is about 1 in 300. Not so rare, right? Our understanding of genetics has increased, and so this is a slide from Brian Traynor at the NIH, and he's an expert in genetics, and in some of his communications, he's really demonstrated our understanding of ALS. So right here is, on the y-axis here, the 0 means you can explain 0% of ALS based on genes. Up here is 15%. And this is including both familial and sporadic forms of ALS. So the SOD1 was discovered around 1993. It explained a few percentage points of ALS. And most recently, we discovered this chromosome 9, ORF72 expansion, which helped us to understand 40% of familial ALS and about 10% of sporadic ALS. And new genes are being added almost on a, seems like a monthly basis, where people are explaining one gene or another and its connection to ALS. But we also have to recognize that genes don't tell the whole picture. And I think one of the challenges that we face is that we always rely on some of these mouse models. We really have one mouse model that's used. It's the SOD1 mouse model. And when people come up to me and they say, look, this worked in a mouse, what does this mean? This must work in a person, right? We have to understand that we're excited. We're always excited when something works. But we have to recognize that there's a little bit of bias. And what I'm demonstrating here, this is actually something called a funnel plot. And a funnel plot is understanding how experiments work and whether or not the results are presented only in a positive sense, only in a negative sense, or whether the whole picture is described. And at the very top here, this right here should be what we call the most precise study, meaning the best possible study with the best possible science, the highest number of participants, or in this case mice, should give us this outcome, right here at the top. And because we know science is never perfect, some studies work and some studies don't work. And so there should be an equal number of studies falling on this side, which is the positive outcome, and an equal number of studies falling on this side, which is the negative side. And so this is a review by Michael Benatar at University of Miami where he was demonstrating some differences in the way the mouse studies are done versus what's published in the literature. And so this demonstrated the difference between onset dates. We can see that this is what the plot should look like. But over here we see there was a lot of missing studies, right? So those are things that are not published. And if we look at survival differences, it's even more pronounced in that only these positive studies are published, but these negative studies aren't being published. And so we have to be careful not to get misled by animal models, but we also know that animal models may not be the way of the future. So while they're exciting, we also have to realize they may not tell the whole picture. And SOD1 is a very complex gene. There are lots of variants. I say they make me dizzy. I can't keep track of all the numerous changes that people have described. In fact, what's really most incredible is the most aggressive form of SOD1 in a mouse does nothing. So in a person, it's the most aggressive form, it's the fastest, but you put that form in a mouse and nothing happens. So that's also our challenge, is how do we better represent ALS in the lab so that we can find better treatments? So what are our research priorities? So we want to defeat ALS, right? How are we going to do this? We have to understand the risk factors of ALS. What's driving the disease? We have to understand the genetics. So what are these differences in our biological makeup, in the building blocks of our bodies that tell us why somebody may be more likely to develop a disease? There's been a lot of discussions about the immune system. So what is the immune system beginning to tell us? How does the immune system change over the course of ALS to make it so that this may cause the disease to progress? We have to do clinical trials. We have to test drugs. We have to test biologics. We have to make these trials faster, leaner, meaner, right? We need to take things from the laboratory into the clinic as fast as possible so we can see if these drugs work. And we need to really tackle these hurdles that slow down our research. We have to do fundraising. It's really important to raise money to do this work. We have to improve clinical care. We have to figure out what drives clinical care, what are some of the improvements, although they may not alter the course of the underlying disease, but what can we do to improve the care for for you guys and for other patients with ALS, we have to better understand the pathology of ALS. What's happening at the very finest levels? What's happening to cause proteins to build up, to cause some of the cellular mechanics to work improperly? And lastly, but not least, we have to discover biomarkers. And a lot of attention has been paid to differentiating between a biomarker that says whether or not somebody has ALS and a biomarker that says you're a normal person. But for those of us that see ALS, that's not really the most interesting clinical question. What we need is markers that help explain, is a drug working? Is a drug being given, and do we see that drug is targeting the mechanism that we're trying to target? And can these, whether they be test of blood or spinal fluid or other markers, whether it be MRI or other imaging, does it tell us that a drug is working at a faster pace so that we don't have to wait for clinical outcomes to occur? So here's how we have to defeat ALS. There's a lot to do, but there's a big committed research community to getting this accomplished. So I'd like to spend some time talking about some exciting work that we're doing at University of Michigan to really help us understand some of the environmental risk factors of ALS. Look, life's a drag. And so the way that I think about this is that this is a news clipping out of England, and it says, Winnie, 100, smokes for 93 years and she ain't quitting now. And I think we all know people who've really smoked their whole life and never really had a problem developing cancer. But we also know people who've never smoked and they get lung cancer. We know that there is some risk from the environment to cause different types of diseases. Smoking is one of those. So why do we want to study the environment? So I'll explain this slide in a second. But basically, we all harbor changes in our genetics that make it so that we're more susceptible to environmental toxins. But if we don't get exposed to these toxins, we're really never going to develop a disease. So let's think about a hypothetical population here. So here I've illustrated a bunch of people, and let's say that in the gray we have people who are at risk. So because of their genetic makeup, if you expose them to the right chemical, they may be at risk of developing this disease. And so let's say, for example, we expose people with a toxic exposure. So we have a toxic blob, right? This toxic blob comes in, and maybe what we'll do is we'll call this blob Slimer, right? So Slimer will come in, and we need to figure out how to eradicate these toxic blobs. And so people get exposed to this toxic slime, and you can see here that only those people that got exposed, the ones that are in this sort of, depending where you look, a reddish color, they get the disease. But the people who are in gray, those that had that underlying genetic susceptibility but never had that exposure, they don't get the disease. So we need to really begin to understand what are these risks at play that we think are really driving this rate of ALS. This brings up this idea of what we call the explosive, the exposome. Tripping over my own words here. And it's a way of really categorizing a lifetime of exposures to toxins. It's something that's almost impossible to do. I can't go back in time when you were first born and really get an idea of every chemical or every toxin or every heavy metal that you were exposed to from the time you were born to the time that one had a disease. But we really need to do our best to do it in a way that's very scientific so that we can demonstrate links of the environment to the disease. And the reason why we want to do this is this idea of what we call a gene-time environment hypothesis. And so on the top is, what I illustrate here is that there are individuals that have this risk of developing a disease, but they never cross this threshold. They never really have enough factors that build up to push them over the cliff. On the bottom, you take the same person, they have the same genetic load, they have the same genetic risk factors. All of our cells change as we get older, right? The body never works better as we age. The mind gets better, right? But the rest of us break down. But then, as the environment plays a role, it may just push us over the edge. Just kind of nudge us just enough to make it so that we cross this threshold and ALS starts. What we know about ALS is that people in Michigan seem to be more greatly affected. I don't know why, we can't explain why, but the Midwest and the state of Michigan seem to have higher rates of ALS than the rest of the country. What we are thinking is that it's related to chemicals. And so on the left here, we show areas where people are passing away from ALS in the state of Michigan. And on the right, we see areas where there are really defined toxic sites. These are defined by the Environmental Protection Agency. They say toxins have been dumped here or stored here. And so we think if we just kind of use our imagination and overlay those two graphs together, that they seem to line up. Well, we really need to look at this now scientifically, and that's what we're beginning to do. So we recently published on this, and some people in the room here may have been a participant in this study where we looked at the association between people having ALS and in association with environmental toxins. So we looked at 3 chemicals that we were able to measure in the blood. One were chlorinated pesticides, brominated flame retardants, and bichlorinated biphenyls, basically coolants and electrical equipment. These were all chemicals that are highly persistent in the environment. They stick around. Once they get in there, they're not going anywhere for hundreds of years. And we get exposed. We get exposed without our knowledge through the environment. What we found is that people with ALS have higher exposures. So if you fall to the right of this dotted line here, the concentrations of these chemicals in your blood is higher than if you fell to the right. People with ALS were on the right side of this graph. I can't explain why, but we need to begin to understand how this is contributing to the disease. I don't just think it's a coincidence, and we're working hard to help explain this. I think we were really fortunate that this research was covered well, and actually it was covered in the New York Times. I think the awareness of this link and drawing greater public attention is really going to help move this research forward. And so one of the things that we've done is we've established this University of Michigan ALS patient repository where we collect biofluids, we collect blood, we collect urine. People fill out a survey of exposures that they may have experienced in the past. And we use all of this information to help us to begin an individual profile of what may be driving ALS, especially for people here in the state of Michigan. Remember, we're focused on you. All right, well, so I couldn't get through a talk without discussing stem cells, so I'll touch on this briefly, and I'm sure I will get some questions. We have a nice team of people, both at Emory. We took a trip to Emory before we started our surgeries here. We have a nice team. I've talked to many people about this trial that we just finished now, maybe about 1.5 years, 2 years ago, where we escalated the injections of stem cells in the spinal cord over time. And in the first group, people got 2 million stem cells, and in the next group, there was 4 million stem cells directly injected into the cervical spinal cord. And we upped that to 6 million stem cells, then to 8 million, and then we gave 8 million stem cell injections into the lumbar spine and into the cervical spine. Now, this was designed as a safety study. It's really too soon for us to, I think, really begin to understand, did we change or alter the course of ALS? But I think we're fairly convinced that we didn't do harm. That's really the first step in science, is make sure we don't do harm. On the whole, most people tolerated the procedure safely. There were a couple events that were concerning to the researchers. Right now, we're trying to move this trial forward. We're trying to move this to the next stage, and we hope to begin this at some point in the future. So, before I start talking about what we're doing at the University of Michigan, I want to talk about research participation. So we need you, right? We cannot solve this disease without people helping. And so, what are the barriers to participating in research? Well, we as researchers need to ask you to participate. We have to say, I have a study, would you like to be in it? So that's problem number one. It's also difficult to travel to a study site. It's hard to come if we ask you to come once a month or every other week for a period of time. It's really hard. For clinical trials, sometimes the inclusion criteria is narrow. I don't like it, you don't like it, we don't make up the rules sometimes, and it's really hard to get people into a clinical trial at times. We have to improve access to multidisciplinary clinics. These are where the research is occurring, this is where the trials are being done, and so for people who may not go to a multidisciplinary clinic, they may not be eligible to be involved in research because they're not around it. I think we're very lucky in this area that there's some really tremendous ALS clinics in this region, and so we have that benefit. But there are people who live in the northern part of the state where it's not so easy to access an ALS clinic. And we have to really formalize methods of studying off-label therapies. You guys see them, they're all over the internet. You know, something works for somebody, something may not work for somebody else. How do we begin to understand all of these different therapeutic options, regardless of whether they're coming from the scientific community or coming from the patient community? And a brief word on that, one of these things I mentioned in clinic is people ask me, well, what do I think about this therapy that's on the internet? What do I think about that therapy that's on the internet? And there's a resource out there called ALS Untangled that begins to try to discuss some of these therapies that are described on the internet in a scientific way. Do these therapies have a biological plausibility? Are they engaging potential ALS targets? Do they appear safe? Can we ensure that the people who took those therapies had ALS? And can we look at their medical records and say their ALS got better? That we know from objective findings that their ALS got better, because what we don't want is for people to be taking some of these therapies that are not well studied and putting themselves at risk. And I do need to give a really warm thanks to Rick Bedlack. Now, for those of you in the back, this may be hard to see. There's a lot of people in this picture, but Rick is the guy in the pink suit, okay? So Dr. Bedlack, who's at Duke, has really taken the lead at running this ALS Untangled. And I really think it's a tremendous resource. It really helps me answer some of these questions, and I think it's a really valuable resource that everyone should know about. So how do we create a future free of ALS? We need you to participate in trials, and not just clinical trials. Everybody wants to be in a clinical trial. I try to put everybody into a clinical trial I can, but we need participation in every research that we have. Register for the National ALS Registry. Run through the CDC. It's a way of beginning to help us understand why ALS is occurring, not just in Michigan, but the whole country. It's really important to register for that. I know for those of you who come to our clinic, we bring iPads to you to help you register, but certainly you can do this at home on the internet. Advocating for ALS nationally. I know the audience that I'm speaking to, but the ALS Association does have advocacy efforts where they have people in Washington trying to help with this disease, eliminate some of the barriers that exist with living with this disease. And if financial support of research, it's really tremendously important. We can't just do this with government dollars, we need help. So what are we doing at University of Michigan? So let me just walk you through the studies. So what are the clinical trials that we're doing? Well, the first one is this T-receptive study, Vitality ALS. We have about a week to get people in. At the bottom of all these slides, I have Jana's email. Oh no, it's cut off. All right, that's not good. So at the bottom of it, if one of the tech guys is here, and can help me sort of move up the slides so that the email address appears. But the first one is this drug of T-receptive. Maybe what I'll do. Oh, so if you look over on this screen, if anyone has a question about any of our trials, if you can read that email address at the bottom, write that down. Jana's our lead research coordinator, and she'll be able to really address any of the questions that you have, whether or not I qualify. So the first one is Vitality ALS. It's a drug looking at strengthening really the contraction of muscles to see if it gives a benefit of improving respiration over the course of a year. You have to have a diagnosis within the last 24 months or 2 years. Your slow vital capacity has to be greater than 70. And if you use a BiPAP or a CPAP or other non-invasive ventilation device, you're not eligible. We're getting ready to start Retigabine. I know we've been waiting a long time, and I think we're getting closer. This is an epilepsy drug that we think reduces the excitability of motor neurons. When motor neurons are too excited, we think they die faster. And this uses some new outcome measures, what we call transcranial magnetic stimulation, where we actually send a magnetic signal to your brain and record that down in the hand. And also do a lot of nerve shocks in your arms to measure the threshold of some of these motor neurons. We hope to be starting a trial of a drug called mexiletine, which also is targeting the excitability of motor neurons, not yet running. I don't have information about the stem cell trial at this point. We hope to begin it. I don't have a target date. I know every time somebody asks me about this, I say the same thing. It hasn't changed. We're working hard to try to get it started. I don't have a time frame for it yet. I don't know what the criteria are going to be. So I can't really say more at this point. And one of the new studies that I'm really excited that we're doing is using, there are some people who use a BiPAP device. We all know that mask doesn't necessarily work well, right? So you have that mask over your face and it may be uncomfortable, or the air may leak out around it, and you go through mask or mask or mask. What we're doing is we got some seed money to start the study where we take a 3-dimensional photograph of your face, and then we actually 3D print a mask to fit your face, so to your anatomy, hoping that it will improve the compliance and the ability to use a BiPAP. And so as you come through our clinic, we're looking at people who are eligible for this trial. Let me talk about the observational studies. We mentioned briefly just earlier about identifying the environmental risk factors, genetic risk factors, epigenetic risk factors. The criteria to get into this study, you have to be able to communicate in English. That's it. So we take everybody. As long as we can describe the research to you and know we can communicate so you understand the risk, everybody's included. And I think it's really important for everybody to help us begin to understand these risk factors, because we can learn a lot from you. And we have a brain and spinal cord donation program where understanding that this is really valuable tissue and that we learn a lot from this tissue. And the way to do this is if you've ever been a patient at the University of Michigan, that's it. It doesn't even have to be a patient in neurology. So if you've ever been a patient at the University of Michigan, if you're registered in our system, have to kind of live a certain distance. We actually get donations to cover transport costs, but that's it. We know this tissue is really valuable.
What did your wife say you don't have a place?
There's still one in there. So what are we building towards? Really what we're trying to accomplish is this idea of personalized data and precision medicine. We really need to understand what's happening, because as I talked about earlier, this is not one disease. What's happening to one person in this room is not the same as what's happening to another person. All ALS is different. So how do we do that? Well, we think about coming to the clinic. What do you look like? What are your features? How can we use our medical record system to begin to understand your particular features? What are the exposures in the environment? So how are those exposures changing the way your ALS works? What are your different genetics? How are the genes different? How do those genes get changed by the environment? If you're exposed to a toxin, why did the expression of some of the proteins that come from your genes change, or how do they get altered? What are some unique imaging signatures? So when we do some of these advanced MRI techniques, what's changing from person to person? And how do we combine the immune system with all of this? How does the immune system change the way that ALS is working? So we take all of these aspects and we really create this personalized picture of ALS for you. And what I envision is down the road, we say, we do a blood test, we do some other tests, we do some imaging, and we say, here's your fingerprint of ALS. this is what we think is causing ALS in you, and here are maybe a combination of drugs that's going to target your ALS. So we treat every person individually. I think this is where the field is heading, but we have some work to get there. What are some of the imaging studies that we're doing? So we're doing MRI, we're doing PET studies. What we've demonstrated with MRIs is that there seems to be a loss of this inhibitory neurotransmitter called GABA. And when you lose that inhibition, our motor neurons become more excitable, which we think makes them die faster. And we can look at some of what we call the diffusion tensor imaging characteristics. We can look at some of the brain tracks, the wires that connect our brain to our muscles, and see how those change with ALS from person to person. And we can use PET imaging to really demonstrate areas where somebody with ALS may have more inflammation here compared to somebody that doesn't have ALS, that doesn't have some of this inflammation. And so for these imaging studies, we really look at everyone who's been recently diagnosed with ALS in the past year, and you have to be able to do an MRI. It's a small tube, you have to lay flat for an hour and a half. It's really hard to do that, but those machines are really uncomfortable. I think many of us in the room have gone through that. We know they're uncomfortable, but I think we're going to learn a lot of information from it. And we're also looking at different ways of measuring respiration. So this is an ultrasound of the diaphragm. You can see this is on the right side. This is actually the liver. And where these boxes are actually the outline of the diaphragm muscle. And so what we do is we measure respiration in the clinic as you blow into a tube, and we measure your respiratory function. But that's, I think, is not a perfect test. And we need to find better ways of measuring respiratory function. I think this is especially important because a lot of clinical trials exclude people because their breathing function is not as great as we would want it to be. And so if we can find better ways of tracking respiratory function over time, I think that'll help more people to be involved in clinical trials and potentially give us better outcomes. So that's an overview of what we're doing here, well, not here, but down the street at University of Michigan to really solve ALS. And I think this gives you a really nice overview. I think, to conclude, we've been through dark skies. Today's not the most beautiful day. Actually, this was last Friday. I was walking out of the building and I saw this, and I said, and I took a picture. And I said, boy, this really is a perfect way to end my talk. Even when there's dark skies, there's always hope. We look for hope every day. There's always a rainbow shining through those dark clouds. There's brighter days ahead of us, and I really think we're getting closer to a cure. I'd like to thank all of the people who help us with our work. We all have heard of Eva Feldman, and she's really a tremendous motivating force for ALS in the world, and we're really lucky to have her. So she supports my career, and I have to thank her personally. And so thank you very much. Thanks for coming. Thanks for braving the traffic and the weather. Is open for questions. I think, is there a microphone? Should have asked about that. If not, I will repeat the question. So try to keep them short, because I won't remember it if you ask a long-winded question, I won't remember it. So try to keep it short. Yes?
Is the JAMA study available online?
Yeah, it's free. So if you Google, my last name and JAMA, or University of Michigan Environmental Toxins, is actually free for everyone to read. We're really actually thrilled that they don't do that. Somehow they let that be open. Yes? Sorry, can I interrupt you? Sorry, the question was, I promised I would repeat the questions and I didn't. So the question was, is the JAMA study available online and is it free? And the answer is yes, and if you just Google, you can find it. I apologize for cutting you off.
No problem.
Go ahead.
Somewhere along the line, I was told that suggested that other members of the family, the children, should be tested for ALS if you have it in your family.
Sure.
Is there any truth to that?
So the question is, if I have ALS, should I be tested or should my children be tested?
My children,
Okay.
especially my male children.
Okay,
Or
so-
yes.
So if I have ALS, should my children be tested for genetic forms? So I discourage that. I think what is important for us to begin to really understand ALS is, are you affected by genetics? The reason why this is important is that there are therapies that are being developed that are in the pipeline specifically for certain genetic mutations. So if you have one of those genes and there's a therapy out there that would help you be eligible for a study. More importantly, or equally as important, if you have that gene and your family knows about it, if down the road there was a therapy that targeted that gene that ever prevented ALS from coming on, then it would be important for your family to know about it so that they could get tested. Now, we don't test people who are not symptomatic because there's nothing different that we would do. It would create brief aggravation. It may have some implications on ability to get long-term care insurance, life insurance. We don't do that. But I do think it's important for most people to get tested. The challenge that we run into is that it is not covered by insurance costs, and some of the genetic testing can be costly. We're working on some ways to make testing more freely available to people. We're not quite there. But I wouldn't recommend that family members get tested at this point. Other questions? Yes?
A question about, if somebody chooses to have genetic testing done, would you also recommend genetic counseling for the results?
Sure. So the question is, if somebody has genetic testing, should you do genetic counseling? Genetic counseling is always really helpful. And so, short answer, yes. The answers are complex, and understanding what this means with some of the information that I showed you, we know that people that have the same mutation in the same ALS gene within the same family may have vastly different forms of disease. And so there are some very good genetic counselors in the country who really understand this. The challenge is finding sometimes a genetic counselor who really has the knowledge. There are excellent genetic counselors who will do research and really help guide you through this, and genetic counselors are always helpful. Yes?
With the clinical trials, one of the exclusions for most of them was a seizure disorder. Why is that?
Oh, so the question is, why are, for some of the studies where we use transcranial magnetic stimulation, why are seizures a exclusion criteria? If I send a signal to your brain, I may cause a seizure. And so we don't want to do a measurement where I could cause you to have a seizure, because that can put you at risk. And so that's why. Yes?
What does the pure gene do with regard to ALS?
Which gene?
PURA.
So the question is, what is the PURA gene? And I have to apologize, I don't know that off the top of my head.
Sir,
Yes.
2 questions.
Yes.
I currently am seeing a neurologist, Newman at Henry Hospital.
Yes. He's wonderful.
Somebody has suggested I get a second opinion on that ALS diagnosis about 6 months. And they suggested getting a second opinion. You'll would obviously be probably the best to get the second opinion. Your comment is not that you still nation.
Right.
Before that, but that idea too, and as far as participating in different research studies.
So
Second question would be, what about donating your organs?
okay. So the first question is a second opinion valuable, and is it something that I should do? And this, so I think second opinions are always great in terms of making sure that you're comfortable with this diagnosis, that everything's been looked at, and to put your mind at ease. I'm a huge fan of Dan Newman. He's great. And it is very frequently where we have people travel back and forth for second opinions. And so that is certainly something that I help set up sometimes, and I know that's something that he helps set up at times as well, in terms of that coordination. One of the things that we are working on is expanding this study to everybody in the state of Michigan. So expanding our assessment of environmental toxins to every person in the state of Michigan, regardless of where they're treated, whether they come to University of Michigan, whether they go to Henry Ford, whether they go to Bronson, or Spectrum, or St. Mary's, the ALS clinics in Michigan, or do they live up north and they're seen by a neurologist in the community, but it's too far to travel to get down to the lower parts of the state. So that's one thing we're working on, because as I mentioned, we need to do a better job of reaching out to involve everybody in research efforts. And if we have some grants in, I have a grant in that I'm hoping will allow us to expand some of the studies that we're doing to really every ALS clinic in Michigan, and even reach out to people who are not at formal ALS clinics. The second question is, can I donate my organs for ALS research, or just in general for overall science?
Either one.
Right, so not getting to an individual level, but yes, your body can be donated for science. We really think that we have a program at Michigan that allows the donation of brain and spinal cord, and if one wants to donate the rest of their body for science, we make that happen. I don't know about other institutions in the state. I'm not aware of programs that they have. That doesn't mean they don't have it, I just don't know about it. Yes.
I'm sure that research is being done all over the country, whether it be here in Michigan, whether it be out in hypothetically California, whether it be in New York, so forth and so on ALS. Do the various research universities talk to each other in regard to their studies, regards to a new process of studying, a new way of studying, or maybe two universities that are working on the same thing, the same methods? Is there a common thread throughout the country of sharing of information?
Sure. So the question is, how does the ALS research community work together, right? And do we work together? And the answer is yes. I mean, absolutely work together. We, as a community, really actually have a lot of meetings throughout the course of the year. Maybe too many meetings, but we're always traveling to get together. And things like these clinical trials that we do are multi-site trials. They happen not just at one center. Understanding risk factors of ALS. There's big collaborations among different centers throughout the country and throughout the world to answer these questions. And so we're really all in this together. It's not just one place that's going to solve this mystery, that's going to solve this puzzle. Everyone from all over the country and all over the world really needs to put their piece of the puzzle in the big picture so that we can stomp out this disease together.
Is there a website that we can go to where we have all of the research?
Right, so is there a website to go to see where all the research is being done? So there is. It's pretty clunky. And there's a website called clinicaltrials.gov. And it's a government-run website where research that meets specific criteria has to be basically placed into that system. These tend to be clinical trials and not necessarily observational studies. The site's a little clunky. There are other coalitions of ALS research. One is called NEALS, or the Northeast ALS Consortium, NEALS, and their website can update, has some updates on trials and things going on around the country. It's probably something that needs more attention, but that's a problem with research in general, unfortunately. The clinicaltrials.gov was designed really to help that, but it's just a hard site to navigate. Yes?
I had an antibiotic called Goutman administered to me several times over a period of 4 years, and all of a sudden I went into anaphylactic shock right after it was administered one time. A couple of years later I started showing symptoms of ALS. My immune system is equestrian. I suspect there is a relationship. I suspect that this drug may have had something to do with it.
So the question is, I was given Levaquin, an antibiotic, and I had a reaction to it, and could this have played any role in me getting ALS? The short answer is I don't know. I don't know. We think there's triggers. It's hard to pin down exactly what those are. I've illustrated to you that I think that there's triggers. I think that there's things that we're exposed to, but we're not at a point right now where I can really say yes, for sure that was a trigger for you or for anyone else. Yes?
Why are you excluding people who had ALS for longer periods of time? How does that benefit the study?
So the question is, why are people that have had ALS for longer periods of time excluded from some of these clinical trials? It's really unfair, right? So it has to do with the ability to demonstrate an outcome. And this is why we need better ways of demonstrating whether or not a therapy is working, whether it be an imaging characteristic, whether it be an MRI or a PET scan or a blood test that shows a biomarker, so that we can see whether or not something's working, as opposed to having to wait to see something clinically. So for example, if a study's trying to demonstrate that, say, hand strength is doing better on the drug, if somebody can't grip to start, it's hard to prove that from an outcome standpoint. And so these are the challenges that we run into, and that's why I think a big hurdle that we need to get over is figuring out other ways to see whether or not we're making some indent on the disease. This is the future. Can we have a blood test or a spinal fluid test or some other test that shows the drug's engaging the target, the drug's doing what it says it does, it's having a biological effect, so it's not necessarily causing a clinical effect in a short period of time, right? But can we show that in a short window of time, the drug's having a biological effect, it's affecting an ALS mechanism, and then using those markers to see in a larger trial involving more individuals whether or not there's a clinical outcome. So it's unfair right now. There's lots of reasons for it, but that tends to be the reason for that criteria. I think there was a question behind me. Yes?
Does ALS mimic other diseases such as Lyme disease?
So does ALS mimic other diseases such as Lyme disease? The short answer is no. On the ALS Untangled website, there's a discussion. I actually think there may be 2 articles on Lyme disease. The ALS, to the trained eye, ALS is ALS, and there are really no other mimics. There are certainly other diseases that we always look out for, and that we always check for when somebody comes to me with symptoms concerning for ALS. There's always things that I look for to make sure that I'm certain of a diagnosis. But we know with certainty that especially Lyme disease doesn't mimic ALS. Other questions? Yes.
With the stem cell research that you're doing, does that also affect the bulbar onset ALS?
So the question is, with the stem cell research that we're doing, does it affect bulbar onset ALS or ALS that affects swallowing and speaking? So we target the neck or the spinal cord, and the area for speaking is higher than that. And so we don't think at this point that the therapy that we're giving is going to benefit people that have the bulbar symptoms or the speaking or swallowing difficulties. Whether or not there are other stem cell therapies, or whether this therapy could be eventually targeted in a different way, but right now, where we can target this safely and not cause harm, is not going to affect that part of the nervous system. Yes?
Since we're really bombarded by all these chemicals in our life now, I mean, from cleaning supplies to what's in our food, like if you go to fast food places, I don't know, do you have a list that you could put out, like what products have what and what you can use instead of that? Like I know that I've seen different things in magazines, don't use this, it's terrible, you can make your own and it's healthier by using, but I can't remember exactly
Sure.
what it is.
So the question is, what chemicals should we avoid? I don't have a list. I think we have to realize that we all can make a difference, that we all live in the same world, that it's a finite area. It may seem like a big world, but it's really small. And I think we all need to consider the types of toxins that we put into the environment. I was having a conversation earlier today where I said, I can walk outside my house and I can see weeds, and I have a decision to make. I can go out and I can decide to get on my hands and knees and yank that weed out, or I can decide to grab the weed killer and spray it. They're both going to accomplish the same thing. They're going to get rid of that weed. But one way is adding chemicals to the environment. And so I think we can all make a difference. We can all think about the ways that we impact the environment. Maybe I choose to recycle something as opposed to throwing it away. We all can make a change in the environment, and I think we need to work on ways as a whole to reduce the chemicals that we put into the environment, to reduce our carbon footprint. I think that's going to benefit not only in us in terms of avoiding ALS, but other diseases as well. There was an article that came out not too long ago that looked at stroke. I'm getting into a totally different area, but they looked at sort of, and no questions are allowed on this because I don't know the details, but it looked at sort of the worldwide risk of stroke and some of the modifiable risk factors, and a third of those factors were due to air pollution. So 1/3 of modifiable risk factors for stroke were due to air pollution. So pollution and chemicals drive disease. And this is in addition to things like high blood pressure, diabetes, and obesity rates.
And you know what, if your weeds are dandelions, you can eat them. They're really healthy. They charge $10 for a bunch like that at Whole Foods.
I can't comment.
I bought them.
I think we have a question over here. Oh, in the back.
By any chance, do you have any update on the Lucent trial that happened on that?
Sure. Any updates on the Lucent trial? I do not. I think we all are looking forward to seeing what Dr. Bedlock finds. Yes.
I was initially diagnosed with myasthenia gravis, and their national organization weren't taking Levoquin. They said it was a black box drug. This is why I was suspectful.
Oh. Right, so I don't know. So the question is, I was initially diagnosed with myasthenia gravis, and so people, if you have carried diagnosis of myasthenia gravis, in general, the class of drugs called quinolones, which includes Levoquin and Cipro, are ideally not recommended to be used. I don't know the specifics of your individual case.
Is there anything we as individuals can do to lessen or reduce motor neuron excitability?
So are there any things that I can do to reduce the excitability of motor neurons? I don't know. So the idea behind the drug riluzole is that it reduces the excitability of motor neurons. And so I think that this is an important drug, although the effect of that drug is not as much as we would hope. But we do need to find ways of say, making Rosal more effective. How can we extend out that therapeutic benefit?
We had heard before that there was very high incidence in Port Huron and Grand Rapids. Is that still the case?
So the question is, are there higher rates of ALS in Port Huron and Grand Rapids? We're concerned about the possibility of these geospatial clusters, is what we call them. So are there clusters of people coming down with ALS? That's what we're trying to find out. So in the state of Michigan, there's actually only one state. ALS is not a reportable disease. Only in the state of Massachusetts is ALS reportable. So you know, it depends on sort of the way you feel. Should every disease be reported to the government? The downside of not being reportable is it makes it more difficult to track. And so one of the things that we are going to try to do is track every case, every new case of ALS in Michigan to answer that exact question. Are there certain parts of the state that are where people are at higher risk of getting ALS for whatever reason? Are there environmental factors driving that?
But did you feel that way before? Has there been anything to say, yeah, that seems to be the case, or no, it doesn't?
So there's certainly reports in the media, but we don't really have anything scientifically at this point to tell us that.
Sarnia is right across the river, and about every 6 weeks they release stuff. My niece is a pharmacist. People come in about every 6 to 8 weeks, and they want stuff for no-grip complaints, a lot of yeast infections. They're sick with that regularity.
Sure. So
And
the
it
comment
kills
was,
the paint off your house too, whatever they release in the air. So, yeah.
yes.
Have you seen any evidence that, like, cyanobacteria can help balloons as a risk factor?
So the question is cyanobacteria being a risk from the algae blooms. And it's an area that's under study right now. And there's some groups studying that. Namely, a couple people to look for if you're interested is Walter Bradley at University of Miami and Elijah Somel at Dartmouth. And they're really leading the charge in helping us to understand what the role is of these algae blooms.
I'm sorry, you said Dartmouth.
Dartmouth, yeah. They're two really excellent neurologists that are helping answer this question.
Can you please repeat the question?
Sorry, the question was the role of the algae blooms in the cyanotoxins, and that Walter Bradley, who's at University of Miami, and Elijah Somel at Dartmouth are two really excellent neurologists who are doing research looking into that question. Certainly, you know, there's been big algae blooms around Lake Erie recently that have caused some challenges, at least in water quality and things like that. Other questions? Yes?
I'm sorry, I think it's the first part of your lecture. Could you summarize the stem cell for
So the question is, can I summarize the stem cell portion? Well, the good news is that I didn't really talk about it, so you didn't miss anything. So summarize our work or summarize stem cells in general?
I didn't know if you were.
I didn't really say anything about it. But why don't I, you know, stem cells are a very promising area, and they receive a lot of hype, and there's a lot of hope around them as well. And we're really at a state where we don't know how and if these therapies are benefiting individuals. There are a lot of ways to get stem cells. So we can get them from your bone marrow, we can get them from your blood, we can get them from donations from things like fetal tissue. We don't know where the best source of stem cells, what the best source is. we also don't know what's the best way to give them. So there's various ways stem cells have been given, through an infusion of blood, through an injection in the back directly into the spinal fluid, to injections directly into the spinal cord, like what we're doing. In other places, they're actually doing brain injections. So we don't know we don't know the best source of stem cells, we don't know the best way to give stem cells, and so these are all questions that need to be answered. And where the field has really sat right now is, can stem cells be given safely? There are some concerns about stem cells. When you have these young cells that may be able to grow sort of uncontested, could they lead to a cancer or tumor forming? In terms of doing a procedure, is the procedure itself safe? That's been the initial hurdle. Now the field is really trying to understand, are these therapies making a difference? Are they turning ALS around? That's where we stand right now, but there's not been really any definitive evidence in my mind to suggest that. I would describe myself as a scientifically conservative individual. I'm not going to get into my political beliefs, this is not the right forum, but scientifically I would say that I'm conservative, so I like to see data, because it's hard to know what to make of information without seeing numbers. There's a lot more work to be done. It's all really exciting work, and I think it needs to be done. So that's sort of my summary. That is an area that needs advancement, just like all the other areas that I discussed.